Hopefully it's not just us two. I'm just gonna, oh no, it's fine, I'll stay here. Just checking the link is the same, MDDM. Hello, welcome.
Hello
You're
there.
the first.
Is it just us?
I think
Compact
no,
and
well, I
bijou.
think it's a very nice conversation we can have, but I think people will start jumping over in a second.
Yeah, sure.
I'll repost the link to promote this session. And I'm assuming Hugo will join shortly as well.
Yeah, I'm hoping Hugo will join because he's got all the material.
Yeah, I've got a copy of the slides here as well, if anything, so. Yeah. Oh, I thought people could just join in. Welcome, everyone. We'll be starting just a minute. We'll let people jump across.
Abdul, can I just ask? We know each other from previous life at ESNEFT.
Yeah, I was thinking of this as well. Is that from ESNEFT or is that from West Suffolk? I couldn't work it out. I was like,
I came from ESNEFT. I was an operational lead there, so we might have talked about, what were you working on there? Costing?
No, I've always been an analyst, so I'd have been either in the medicine analysis team.
Yeah, medicine.
Tester,
yeah.
So.
You're definitely familiar. We've definitely had a conversation in the past.
Yeah. Small world.
It is.
Welcome to everyone joining across. Good to see that the link worked. It's always that worry. But we're just waiting a minute for Hugo. He's coming from another meeting. He will be sharing slides and presenting. And
I was also going to say, Edwin, we had a few requests as people were leaving the last one for a quick 5 minutes for people to have a comfort break. Should we start at 5 past just to give people an opportunity to join?
Of course.
Because I think it always takes a little bit of time. So if anyone is wanting to grab a very quick cup of tea.
Yeah. I was actually going to post that in the chat earlier because I said, if you want a cup of tea or break, don't just go. We won't be offended. And we've got other meetings too. So do what you need to do, and we'll start at 5 in a few minutes. Welcome, Hugo.
Hello, welcome everyone. I was still on the previous session, so that's why I'm a bit late.
No worries. We've got a good number joining, and I've started recording the session, and good to see a good number of people.
Technically, and start to share my slides, Edwin. So
yeah, do you want to share?
We can use this time. Yeah, we can use this time wisely to be sure that everything works fine.
Yeah, I've got a copy here as well if you need, but if you're able to test that the slides come up. Your connection's slightly choppy. I don't know if you have anything running in the background, Hugo.
Yeah, tons of stuff. So
yeah, I don't know if that will help to. Alice, can you hear Hugo? Okay.
Yeah, I can hear all right.
Okay, that's good.
Well,
if anyone,
can you see my slides? Or not yet?
Slides are all nice and clear.
It's not full screen. Don't know if it's able to go on the slideshow tab or this button to make it full screen.
Can you see it full? Well, still not presentation mode, but
yeah, that's much bigger. Okay. Hopefully that way you can see us as well.
Unfortunately, I don't think I can. So.
Oh, okay.
Oh, well, let's try something here. Well, we have 2 minutes, so let's play around with Teams.
Yeah. For anyone just joining, we're just going to start at 5 past. Just allow people to have a little bit of comfort break and get a cup of tea as well. After this session, we'll be having lunch, of course, very important. But if at any time during the day you need to go away, if you've got a meeting, if you need a break, just go away, go do your thing. We won't be offended, and we recognise that everyone's busy and need a break time to time. So we've got quite a few people now, so we could probably make a start. Oh, great, it's full screen as well now.
Yeah.
So Hugo, so welcome everyone to the session. Without further ado, I'll just pass you to Hugo who starts.
Okay, thanks, Edwin. So my name is Hugo Herrera. I am Head of Analytics at Suffolk, North Essex from NHS Foundation Trust, so ESNEFT. And so I'm aware that, it's probably lunchtime for some of you, and some of you might be enjoying it at the moment. So hope you do, but some of you might be waiting for this to be done to go for your lunch. So I will try not to take the hour. I think we probably will do like half an hour, 40 minutes, I think, and then we can, open the floor for questions and discussion, and we can stay along, if you want a bit longer after that, discussing anything you would like to know. So this is the title of the presentation. So how System Dynamics approach can help you with this. We have been focusing or analysis in doing demand capacity and understanding what are the challenges that we are facing as trust, and now at an ICS level in terms of demand capacity, how can we strike the right balance, and we have been using System Dynamics to do this piece of work. So what we're going to share today with you is a bit of our journey and how did we get to where we are, what we're doing, how does it look like, etc. So I want to start by recognizing the team. I think it became evident in some of the previous presentations, that this requires a lot of effort, time, leadership, and support. So in the ESNEFT team, you see that because I have a big team that works for me, so I can mobilize them to or ask them to support us in this project. But we also have the support from Alex Royan, that I think is in the audience right now. He's program director at the ESNEFT, and Alex support has been incredible to actually to take this off and to be able to develop this and get the buy-in from all the stakeholders that we need, not only at the trust level, but also at an ICS level. I am a system dynamicist by background, so I have a master degree in system dynamics. I did my PhD using system dynamics methodology. So that gives us a bit of an advantage in terms that, well, we already have an expert in system dynamics in our trust. And so you will see that we dare to kind of scale up and ramp up our development relatively quickly. So I just want to mention that as if when you see a path that we're following, if you want to do something similar. Abdul and Robin have been instrumental to do this. Well, they understand very well system dynamics. They have taken it on and they understand very well the system. We have a team of senior analysts, and you see their names there, that have been supporting us on understanding the system, how each of the different specialty works, what are the differences between them, how the flow patient works. And we have our external partners in NHS England and DAS that recently have started to work with us. And despite the fact that we have all these people internally working on the project, I think their support has been also very important, because it is a big task. So I don't want to disencourage anyone to do something similar. I just want to recognize that it is the effort of many people, and because we have all these people and the external partners and internal capabilities, etc., is that we have managed to scale up relatively quickly. And this has been our journey so far. We started roughly a year ago, and initiated by a conversation I had with Vanessa, and we started to work. We pick up pilot projects similar to what Norfolk and Webney did. We were looking at colorectal surgery, RTT, in our trust, particularly in our Ipswich hospital. In parallel, Abdul, that he had some experience doing system dynamics, he started to do some work on language therapies in our community services. And that roughly lasted until February. And I'm going to explain a bit more of the process that we went through there. But basically what we did is we were running like kind of 3 streams at the same time. So we were trying to develop a model that would give some insights. We were trying to show people and demonstrate what the model was capable to do. And we were also interested in developing the capability, learn about system dynamics, and train some for analysts on how to do system dynamics, how to build system dynamics models. And that was possible thanks to support of Edwin and Vanessa, that they were doing a lot of the training themselves. And that was instrumental, I think, to the first step to actually be able to scale up and do more interesting projects. We finished that stage around February, and after that we have additional system dynamics training, internal training that we need to polish some of our skills, to discuss a bit more about archetypes and delays, how to manage more technical bits in the model. And around the end of April, beginning of May, we started a big piece of work that we are about to finish right now. That is a demand capacity model for the acute part of our ICS system. And this is part of a wider project where we are trying to get a systemic understanding of the whole for ICS. Because we have gone through this process in ESNEFT, where we're decided to start doing the system dynamics bit for acute, where we actually have the capability. And at the moment, the other models are mixed models, let's say, in terms that they use different methodologies and different approaches, but first they can be integrated with our system dynamics model. And I think the ambition will be that at some point we can incorporate other elements as well within the within our system dynamics model. Why system dynamics? I think we have discussed extensively this morning, so I'm not going to spend too much time preaching to the converter, but you see a quote from networks.nhs.uk talking about why simulation models are important, why do we need to do something different. I think after some of the examples that you have seen this morning, we all have seen the potential of having a flight simulator, to having something you can interact with, and the power that gives to stakeholders to actually understand their system and make decisions about it. As I say, our first model was about colorectal surgery in our Ipswich hospital, that's based in East Suffolk. And we have 3 objectives with this experience. The first one was to build the capability. I think that was the main objective of this project, was to train analysts within the trust on system dynamics, getting the software, developing all the tools that we will need so that we can use this on a regular basis. I would suggest that taking a case study or picking a project is probably the best way to do it. Otherwise maybe it feels too abstract, too disconnected of what analysts do on their daily job. In fact, that we were working on a project from day one with some of our analysts not even knowing, what was system dynamics, but they were already day one already working on it. I think it was very good. It really gave us a purpose and a sense of direction and a way to see it really apply in concrete settings. The second one was to create awareness among stakeholders. As it has been said as well, system dynamics and in general simulation models are relatively new to the NHS. It's not what we usually do. let's put it that way. So it's important to create awareness and to show people, this is something that it has been out there for many years, and it has been used in different industries, different sectors, and it's fantastic. And and definitely there are opportunities for you to benefit out of it, and demonstrate the art of the possible, and to show them, well, what actually can you do with this type of model? How far can you push what you normally get out of your data if you put it into a system dynamics model? And the process was very simple. So we have 3 stakeholder engagement sessions with our operational colleagues, some support from senior stakeholders or associate directors and the directors of divisions were attending some of these sessions. And I pretty much did a problem definition one, where Vanessa and Edwin facilitated this session, and we scope what kind of issue we wanted to tackle. Then we have a system mapping one, working closely with operations to say, well, how does this work? How do the system flow through colorectal surgery specialty? And once that we have a model, we have a bit of a model discussion, what this is. So this is kind of a qualitative part in system mapping, a discussion about the structure of the model. And this one was more about the results and the outcomes. One, this is what we could expect. This is where we see the bottlenecks and the issues in terms of colorectal surgery pathways, and what can we do to try to reduce our RTT waiting list. And in parallel, we were having some training provided by NHS England, and we were doing the modeling work. So Abdul, Joshua were participating actively in the training. They were learning from the basics, from how to build the Stockholm flow diagram, how do you put the equations in the model, all the way to developing interfaces and interactive learning environments or interactive flight simulators that you can use to interact with the model. And they were doing this while they were doing the work, the modeling work. What did we do? And this is our first model. As I say, you can see there it is. We split the model between 2-week waiters, routine referrals, urgent referrals, but basically the structure was the same. We have patients waiting to be seen, then patients waiting to be diagnosed, then some of the patients will become severe, what they were waiting to be diagnosed, and we have people waiting for surgery. So, and you have different flows in between these stops. What these were 4 main stops. People being referred to the system. Then once that they were seen, they will be waiting for being diagnosed. So basically, people waiting for endoscopy in this case. Some of them will luckily be diagnosed negative, and they didn't need further treatment. They didn't need surgery, and some of them will be diagnosed with cancer. They will, because we were focusing on colorectal surgery, we didn't include here obviously chemo treatment or other forms of treatment, but we focus on people that will be referred actually to surgery, and they will be waiting for it. And something that we were particularly worried or concerned about when we were building the model was people that was, because they have been waiting for too long, they will actually come at a more severe stage to our surgery, or actually they will come through the emergency. So actually they will not, because people have been waiting for too long without receiving proper treatment, they might actually show up in the emergency with a more severe case that needs to be treated urgently. And I'm going to be totally transparent. You probably can identify there like 100 of things that we're missing, and it was because it was just the first model, and it was very simple. It's something that we could we used to learn, and and that we use to talk to or to start to engage with our senior stakeholders. However, despite the fact that the model was relatively simple, once that you add all the stocks together, we were getting kind of a good fit for waiting lists. So obviously we can, and that's something you then need to learn to live with in system dynamics, is that, well, you're never going to get like perfect fit. And actually, I will always be suspicious about having a perfect fit in your model, but you can see that the model was reproducing quite all right the main behavior with a bit of a lag in between some of the phases, and this is basically, well, something that we found was because we were running the model in weeks, and obviously things don't happen on a weekly basis, but on a daily basis. Then that was creating a bit of a lag, some of the process, especially for 2-week waiters, and urgent referrals happen relatively quick, and that was not necessarily the best, the most useful data for analysis that was done on a weekly basis. But this, as I said, was the perfect kind of sandpit for us to practice, to learn how to build the model, to, something very simple, 4 stocks, just flow patients in between, a small feedback loop, and to develop, our skills or capabilities, and we were doing this while we were learning, and because we were very successful, I think, on engaging our stakeholders and on selling the benefits and demonstrating the benefits of system dynamics. We were asked to scale this up, so our ICS started to develop a strategic planning process at the beginning of the financial year. So Suffolk and Northeast Essex Integrated Care System, that you can see there, the map is, and all the organizations that are in this map wants to build this strategic plan that helps them to anticipate some of the to understand what are the current challenges, but also to anticipate some further challenges, and to identify what are the leverage points to improve the situation in our area. And because the success and the the good results that we have with our small simple model developed, while everybody was doing another 20 things, etc., in very short period of time, but also because the potential that system dynamics has to capture the whole of the system. So the ICS asked as well, could you do this, but not just for colorectal surgery, but for for the whole of acute? And because ESNEFT manages 2 of the hospitals, of the acute hospital, 2 out of the 3 acute hospitals in our area. So it was just logical to say, well, do you guys develop this and develop it in a way that is also useful for West Suffolk Hospital, so we can use it for the whole of the ICS. And it's a big ask, it's a big challenge to create a model that can be transferable across sites, that covers the whole of what we do, because I think we all here are aware of how complex our systems and our pathways and all the challenges that come with it. So most of the rest of the presentation, the 25 minutes I have left, I will talk about this model, what we did. We are almost to the point where we will reach our first milestone, that is deliver the model for, I think it's 12 specialties that cover roughly 80% or 85% of our total demand. There are some specialties that are way too small, and because system dynamics is based on uses aggregation, is not really good when you have or you get into a lot of technical issues in terms of how to get the flows working properly. It almost becomes a discrete event simulation, as Sean was saying before. So some specialties are definitely out of the scope because there's very small flow, very small demand, and those that are in between, maybe we will address at the phase 2. But obviously those that have the larger demand are the ones that are the biggest challenge. So this is the process that we follow. We develop a proof of concept that was a aggregated hospital level model. That was the blueprint that we can the design of, and that's what we have, a 3D fancy design there of a house, but was the design of what we want to build. It's not the real thing, and then we were very careful to tell everybody, this is not the real model. We didn't build the model in 2 months, but using data at the hospital, we managed to build a blueprint that we could say to people, well, this is roughly how it's going to look like. This is what the model will be able to do, and are you happy with it? And that's the data that we need as well. It helps us a lot to conceptualize what kind of data do we need. Then, and this is the phase that we are just finishing this week, the model development. So once that we have this blueprint, we can take our blueprint and start to look specialty by specialty, how these specialties fit within that blueprint. Where do we need to make changes? Where things are different? And we also need to start disaggregating in terms of capacity. So the blueprint that we produced on the first instance was quite simplistic in terms that it was just telling us, well, you need to see X amount of patients, or you need to treat X amount of patients a week. Well, in the the next step, now we are able to say, well, we need this amount of first appointments, this amount of follow-up appointments. This translates in X amount of full-time equivalents, X amount of clinics. We still cannot get into, and we'll see that in a minute, we cannot get into granular level of detail of tell me how many consultants do we need or how many nurses do we need, because first, the model is designed to be strategic, and second, because there is a lot of complexity in terms of how we organize our workforce and how do they work. So it didn't make too much sense. Well, the model will just grow up out of proportion. And obviously something that it shows here as the end of the process, what we have started to do it while we were building the model, was to do the quality assurance, to validate the model, and to be sure that the model is reasonable. There are other models that we use, normal spreadsheet models that we have used in the past for business planning process. So something that we want to do in the next couple of weeks is to validate. So does the system dynamics model produce something, on specific variables, produces something that makes sense? If you feed it the same data, they produce something relatively similar. We have bed models, and like probably many of you have models to calculate how many theaters do we need, etc.
Hugo,
yeah,
just on that point around quality assurance, we have a question in the chat around how do you demonstrate levels of uncertainty in the model when developing predictions?
Oh, well, we've got to do that in a second. So our model is so our model runs on a stochastic basis. So what we produce is a confidence interval for predictions. So I will explain that in a bit.
Right.
Yeah, that's how we do it.
Just one more question actually, before we move on, from Tina. So Suffolk and North East Essex ICS is in a unique position where the acute trust also holding the community contract. So is there an opportunity to look at community SD at the same time as acute services? And Tina comments, in a lot of cases, the acute and community services will be delivered by the same resources, so the capacity is connected.
Yeah, so indeed, well, especially Northeast Essex is part of ESNEFT. We are working as well in a community model, but because we wanted this to be transferable, we developed them independently. And basically what we have is a link between, the discharges coming from acute are an inflow into the community model. and an outflow out of the acute model. We could link both of them in terms of trying to identify whether capacities in community are affecting lengths of stay in acute. We know that is, we know that happens. However, in our case, it's a very small proportion at the moment of people is actually discharged into community beds. So although we have an issue there, and potentially that issue will become more relevant in the future, at the moment is, it's relatively small. So yeah, in the next steps, when we will start to integrate this with the other parts of the system, with the other models in the system, that is going to be actually community is the one where we're going to start with. Thanks for keeping an eye on the chat.
Yeah, no, thank you. We'll let you get under the bonnet now for the more technical aspects.
So I'm going to split into, first we'll talk about very technical stuff. So if you are not interested in the technical part, you can go for a cup of tea. And after we cover the technical part, I will talk more about how does the model look and what kind of things you can do with it. And maybe, maybe if you are very technical, then you can take the opportunity to go for some tea. This is roughly how our model works. This is obviously very high level. I don't know if our colleagues from DAS are in the room, but they can witness that the model is way more complicated than this. But this roughly gives you the overall view of what we have. So we decided to start with the RTT in a simpler way. You say, the RTT waiting list is just stock of people waiting there to be treated. Once that you treat them, their clock stops, and as soon as they are referred and they're put it into a list, the clock starts, and that allows you to measure obviously how long have they been waiting for it. Some of those clock starts will require to be an outpatient appointment, majority of them, as you probably imagine. Some of them, almost none, will be referred directly to the admitted waiting list. So they will be waiting to be admitted, or they will be referred as a day case. And again, very, very few of them, especially most of these people that have come in a non-RTT pathway, and when they have been seen in an outpatient settings, then they become RTT pathway. Outpatients then have their first appointment, and then they move to wait in a case log where they can be waiting for X amount of, they have X amount of follow-up appointments. Some people will have 1, some people will have 3, some people might have 5. So as I think Sean was pointing out when we was talking about system dynamics here, is where we use averages and we mix everybody and we assume perfect mixing. So everybody comes into that stock, get mixed, and some of them will be discharged after the X amount of appointments. Some people might require diagnostics in between their first appointments, and sometimes you have a diagnostic comes like negative, and then you can just be discharged because you don't need to be seen anymore. Some outpatients will need to be admitted, and while they are waiting, they might also go for diagnostic. Then they will be admitted to the admission unit. We will have some in-day cancellations. And in this admission unit, in between, in the detail model, just out of interest for some people, between you are waiting to be admitted and you are admitted, you have to go to pre-ops. That is a separate capacity, and we include in the model. And then where you are admitted, and although here we are only reflecting the beds, but obviously it also depends on theaters availability. So whether we have a theater to do the surgery and whether we have a bed to admit the person. And interestingly enough, this connection between this flow might result in some of these in-day cancellations. So these two are not perfectly synchronized, because in-day cancellations in theaters, because some people might not be able to, we might not manage to discharge some people, etc. Then you have people that's actually in the bed and then they are discharged. Some of them might have follow-up appointments, very typical in trauma orthopedics, for example. People needs to go to physiotherapists, then they might join the outpatients case log again. And what the day cases is relatively straightforward. You come to the hospital, you have your treatment, and then you're discharged. You might see that because we are trying to keep simplicity without include anything of where the capacity sits. But obviously the flows are driven by your capacity, and then you just have patients moving from one stop to the next based on, you know, how wide can you open the tap in between the different flows using your capacity. For those of you that are not very familiar with system dynamics, so system dynamics is a simplified, but all the models are simplified, but system dynamics is quite aggregated. And you know, we allow, and it has this advantage that because you can aggregate and simplify some structures, you can represent very complex problems like a whole of the hospital, you know, with a manageable model. But that means that, you know, we are not representing every single aspect of the system. So as part of the process, we do a model calibration. So we calibrate our model and then validate our model using historical data. And you see this is, for example, first appointments activity. I have the data of, you know, how many appointments did we have every single week, as many of you probably do in your own trust. And then you see the red line is what the model produces. And you see that the model is quite good, picking the, you know, the drops on false, but it's not perfect, and it's not aiming to capture every single of these peaks and valleys that we have in our actual data. It's, you know, it's not, it has a good fit, very good fit in my view, but it's not perfect. And some people might think like, wow, why are you similar? Why don't you just use the historical appointments as your input? Well, because what I want is the model to be good enough to produce something, to be able to produce something extra, can be extrapolated in the future. And you know, and that's why I validated again my historical and let the model to tell me what this is what I think it will happen, and I compare it to what it happened. It requires a bit of, you will see when we look at the inputs, well, we have some inputs that we use to fit the model, some inputs that we use to validate the model. And what we get out of the model are basically two things: projections. And when we talk about projections, we as I say, we have like confidence intervals. Using Stellar Architect, you can use Monte Carlo simulations, and that gives you a confidence interval. And we also, so the model tells you, well, this is what will happen, and then also tells you, well, how much capacity do you need, and we'll get more into the detail. Well, what capacity do you need for what? Because yeah, it depends on what do you actually want to achieve. This is the counting, you know, what the model is going to tell you. I'm not going to read through this, but I just wanted to. So we took this approach of splitting our inputs in, or splitting our variables into this three aspects of our of the process. So we have inputs that we use to calibrate the model. These are inputs, historical data series from 2019 to 2022 that we use to see if the model reproduced the historical data, to be sure that the structure of the model is right. And we calibrated, or we compare the model results against these historical trends. So these ones we give to the model, these ones the model calculate, and we compare against the historical data, and we see, you know, if we are satisfied that there is a good fit. So these ones we don't, the model has to figure out which ones, it has to figure out these ones, although we have the data. And this is data that we use for projections. So what do we do? So, you know, this is the easy part, where you put the historical data, the model does the calculations. Well, we get our result, and we are highly confident on these ones because we know, you know, what happened in the past. When we need to look into the future, then it becomes more difficult because, well, we don't know what is going to happen in the future. And to come up with this, we came up with three different approaches. One of them was we will just we would just an ARIMA model. So we just use a projection. We statistically produce a forecast of referrals and emergency attendances. And, that's what we feed into the model, a time series. These ones here, the ones that have a number, also relatively easy. What we say is, well, let's assume that bed capacity is a number. You either have 100 beds or have 200 or have 300. So it is a number, and it's a number that we can change as part of our interface and what we play around with. But it's a number, it's just one single figure. And the other type of inputs are these ones that are stochastic, so things that might change over time. For example, the percentage of emergency attendances that actually result in an admission. And what we did in this case was look what has been the average for the past years. We with a bit more weight in the recent, so a pondered average, considering the most recent years are more representative ones, and then we calculated the standard variation, and I think all of them came really relatively normal, so we didn't have to use anything more sophisticated. So just a normal distribution for most of them, I think, and that gives you the stochasticity and gives you that range that we saw in the projections, because we cannot pinpoint a number, but we want to account for the variability of that we could expect within that number. These are just the ARIMA models that we use. I think all of you are familiar with it, or I'm assuming most of you are familiar with it. And the final type of input that we have is we pick up on some parameters, and these ones were, when we were building this blueprint big model, these were variables that we figured that they have relatively small variation, and actually the model was not very sensitive to some of them. So, for example, the percentage of DNAs, some weeks is 4%, some weeks is 2%. But if we tell the model use always 5% to say something, the model was doing quite a good job fitting. So instead of adding more complexity to the model, we decided, okay, these ones you can just keep constant from for historical data and for data going forward, and the results are not tremendously affected by them. There are also things that we are not so interested to look in terms of this scenario development. What the model produces, I'm sorry that it has the wrong title on the slide. The model produces RTT size and distribution, so how big is your RTT and how are they split in the amount of time, or how long people has been waiting. Non-elective demand, so what do we need in terms of beds and day cases for non-electives, and the capacity, how many patient capacity, theaters capacity, inpatient capacity, and diagnostic capacity do we need. And as I say, we didn't do it for the whole of these specialties. We have, after can correct me if I'm wrong, but we have more than 100 specialties. And doing this 100 times, it was impossible. But these ones here that we have, that are the ones that we are working for phase 1, cover about 80% of our total demand, as I said at the start. So these already give us a good representation. These ones on the right are the ones that we would like to do. Actually, we have started to do some of them, like cardiology and neurology already. And this one will, once that we cover these ones, we cover majority. And the other ones will just be expressed as others. So we just have other specialties that give us the total of at a site level. At the site level, we will not be able to look at required capacity in diagnostics because of some challenges that we have around diagnostic data. If any of you have been doing some demand capacity modeling on endoscopies or MRIs or CTs, you might sympathize with some of the problems that we have encountered. So unfortunately, we cannot offer that at a site level, but pretty much all the other ones we do. There are some questions that we, this kind of what if questions, I think have been mentioned before, what kind of questions the model can answer. So I'm not going to talk too much about that. I prefer to talk about the ones that we are a bit limited. Actually, Sean and the presenters in the previous session talk a bit on the emergency model runs on a weekly basis. So it really gives you very limited information about emergency department. As I say, we have some issues about diagnostics, so it really gives you limited information about diagnostics, and it gives you limited information about, you know, how many. Could you tell me how many consultants should I have in this shift, or how many nurses, or, you know, should this person come 3 days a week or 4 days a week? I wanted to highlight these limitations because I think this really, you know, drives the point home that you need to set up your scope, and that this is, you know, at least that you want to spend probably years building something. It will, you know, it is impossible to get a model that does everything. So we have to pick our battles, and we focus on RTT and, you know, and throughput basically. So the model is focused on throughput of the hospital, and A&E is, you know, very important, but our model is very limited because, you know, if the model says, oh, you know, you are going to have 500 patients coming through the A&E this week. Well, fair enough, but it's very different if you have 400 between Friday and Sunday than if you have 500 split over the week evenly, and that is the level of detail the model cannot account for. You know, or, you know, we can give an indication of how many patients do you need to treat, or how many full-time equivalents you might need on a specialty, but we cannot, you know, dive into the details of where this person does this job, but also does that job, but also helps to do this. So it's going to be 0.5 of this person. It just becomes way too complicated. So an advice or a suggestion from our side would be to pick your battles and to recognize that there are some things that your model will not be able to do. And there's obviously opportunities for keeping developing this further. For example, disaggregation by age could be something, or at least by age cohort could be an interesting area that we want to look at, because we know, for example, that frailty services, that we have an aging population, so that there will be some services that might change in the future. So at the moment, we're just looking at adults and children, and you know, but differentiating between people coming between or below 40, people 40, 60, and people over 60, it might become more relevant, especially if we are looking at 10 years, 15 years projections, where demographics might have considerable shifts. Conscious of the time, yeah.
Just a couple quick questions. Have you had any issues in the model caused by poor data quality in the underlying feeds?
That's a difficult question, because my team is the team providing the data as well. So I am inclined to say no. Well, we obviously have issues with data quality. I think that's, and it's probably because data hasn't been collected, generated, and with this on mind. So, you know, our systems were not designed to think or to do analysis on a time series analysis. So yes, we have encountered some issues. That's the reason why we don't dare to offer major insights on diagnostics. But the fact that we are developing with the team that works closely with the divisions, it has been very helpful, because we can work with them and, you know, and remediate you know, some of these issues while we are developing the model.
And just another question, and Binoy, I would invite you to ask the question yourself, so I don't misrepresent it. Are you happy to do that?
Yes. Hi, Hugo. My question is about the different measures we may have in reality, and how you manage to standardize it for inputting into the model. For example, you know, we sometimes measure in terms of number of patients and number of requests for demand, but the activity and how sometimes we measure the capacity is different. for example, maybe theatre slots rather than specific number of patients as such, and then and also within, you know, in outpatient setting as well, there is number of clinic slots, etc. But essentially, that's an estimate. So how do you manage to standardize that?
So that is what so what we did is we were prescriptive in that sense that we say, well, capacity is expressed in how many patients you can see every week, and you know, that is because we use that, at least in ESNEFT, as the way that we build a business plan. So we look at our activity and how many patients we actually have managed to see. You know, that we can count how many patients have come through these outpatient settings of this clinic, and then we have the world of capacity, where they have like these work plans where, like you say, they have different clinics and different shifts, and you know, but we can translate them, you know, well, and how much capacity do you expect to deliver, or how much activity do you expect to deliver with this arrangement that you have, and that translates again into patients that you can see or you can treat, and but exactly because the point you're making is that we struggle to go back to all these different metrics that people use to express capacity. So it would be a nightmare, to be honest, for us to try to do that, especially across different specialties. It's, you know, they operate in very different ways. So what the model tells the operational manager, you need to, you know, if you want to clean up your waiting list, you need to be able to see, let's say, 100 patients a week. How do you get to that 100 patients a week is for you, operational manager, to get a grip on. We can give you an indication based on some data that they have provided as well. Okay, big, and that's why I was pointing out the team at the start of the call, because those guys work, divisional analysts, they work with the divisions, they help the divisions to build a demand capacity plan. So they already have a lot of data regarding how do you estimate number of patients that you can see based on the amount of clinics, etc. So they can help them to reconstruct back and say, like, okay, well, if we want to see 100 patients, we need to do this and this, or you need this amount of clinics, and you will need this person actually to do 3 shifts or 2 shifts, and but yeah, including that in the model will be,
Thank you for that.
Yeah.
So basically, my understanding from that is that you used activity to define the model and project it. So based on historic activity, that's how you worked out the capacity.
So the capacity came from the divisions expressed in patients per week.
Yeah.
There is the same measure that we use for activity, so it's something that's comparable.
Hugo, conscious of time, thank you for that question, Benoit.
Thank you.
It'd be great if you can give a flavour of the interface in the last section, but maybe not have time to go into great detail.
I'm just going to fly through it. So this is the screenshots of our interface. This interface split in 4 sections: the inputs, scenario analysis, projections, and interventions. The first section is designed so that you can, you have all your inputs in the model, and that's something that I think Keisha from DAST hates me for, but all the inputs are in the model. I want all the inputs to be in the model so that people can input directly and go modify the inputs directly in the model, preferably in the interface, so they can see actually what is the model based on. Then the model gives them opportunity to do a scenario analysis. So the model, as I say, has some ARIMA projections there, but allows you to change those ARIMA projections or change some particular aspects of the values that we were talking before. So, well, for example, length of stay, we were saying length of stay is the average of the past couple of years. but people can say, no, actually, I think length of stay is going to go down by 3% because we are doing this, or by 5%. So you can adjust this when you're working with your scenario analysis. Once that you adjust your scenario, you go to projections, and there is where the model tells you, there is where we have projections, where the model tells you, well, now that you told me all the inputs and what your scenario for the future looks like, this is what you get in terms of the RTT PTL, and this is how it's going to be split between people waiting below 18 weeks, over 104, etc., etc., etc. And by the way, now, thanks to some work that we did with DAS, now we actually can break down this one in even more detail. And so you see your projections, and that is, well, if I do nothing, this is how my scenario looks like. So all these inputs that I gave, the model tells me this is what will happen. And then you can start to think about target, then you can start to think about capacity. So the model will tell you, well, this is the capacity that you have, this is the capacity that you need. But important bit here is, well, the capacity you need to do for what? So it's the capacity that you need so that the RTT stop increasing, for example, or the RTT go back to pre-COVID levels, or the RTT increases at a X pace or whatever. So here is where we set up that target. So we say, well, in this case is a simple exercise of saying, I would just want the RTT to be back to 2020 day levels. I want to be back there in 2 years, and then the model indicates what is the demand, because it becomes quite heavily intensive. So the model only does it for the P20 and the P80 out of, if you remember, we have like a whole confidence interval what things could happen. So the model only picks the low, medium, or high scenario. Usually when you do normal or traditional capacity, demand capacity analysis, you do this one at a P80 or P65, I think it's the two numbers they usually use. And then the model will tell you what is the capacity that you need in, as I say, in patients treated per week. And then in the interventions is where you can play around on different policies. Well, for example, what if I will increase my capacity, or what will be the effect of this? And the model will tell you, well, if you match your capacity to the required capacity, and it will give us a projection. So when you talk down to the projection, it will give you a projection of what happened with the RTT, what happened with the amount of time that people is waiting, etc. So sorry for the non-techie audience, because I think I spent too much time on the techie part, a little time in the less techie one. But yeah, we have a quite good interface. These screenshots are, by the way, from a proof of concept. So remember at the start I mentioned we develop a blueprint proof of concept. These are from the proof of concept. We, still need to develop the interface for a new model that we are developing with the support from decision analysis systems. Sean, Stephen, and Keisha are supporting us on that work, and as I say, it's coming close to an end. So I didn't achieve my goal to let you go earlier for lunch, but at least we will go on time, and you will have 30 minutes.
Yeah, and that reflects the richness of the project and the ambition of it. So thank you so much for that presentation. I'm sure it will stimulate a lot of thought, and you may be some follow-up conversations to be had. As I posted in the chat, to rejoin the main room after lunch, just click leave on this meeting, and then you'll be on hold. So just resume the main meeting. If you get lost or anything, just use the joining link from the email you were sent. So I think we can close it there with 1 minute to spare. But thank you so much, Hugo. Thank you, Abdul, as well. And yeah, we'll reconvene at 1:30. Thank you, everyone.